We're going to give it just like 2 more minutes and then we're going to go ahead and get started. I just want to give people just a minute to get in. A bunch more Jennifers are popping in.
I'm confused. What am I changing my name to?
Oh, we just to your name. Because you come up as Jennifer, Gray, so yeah.
Okay, I see. I'm like, who am I today?
whoever you want. I know who you are, but I just thought it'd be helpful for Rachel, who's presenting today.
Okay.
Thanks for joining us today. I'm really excited to have everybody. I'm just going to give it a couple more minutes and then I'm going to get us started. Wait and see if anyone else pops in. All right. Rachel, are you ready to go?
Sure, yeah.
Okay. So good morning, my fellow FCSers. We're so happy to have you here today. Those of you who may not know me, my name is Kimberly Castle. I'm the Supportive Housing Program Manager for Foundational Community Supports for Western Washington. I also have my colleague Rayanne Orban here, who represents Eastern Washington. We're really excited to have you here to join us in regards to just looking at the different dimensions of fidelity and helping support you and your agency and getting closer to those fidelity scores that we all hope for, and getting closer to being able to serve individuals in the best quality that we can, and thinking about what we can do as an agency and as a team to work towards those goals. So I appreciate you guys taking the time to start working on this with us. We're really excited to have Rachel Post here from TAC, who we've been working with for the last 5 years in foundational community supports and providing support around the initiative and supporting you as providers to do the work that you're doing. So I appreciate you guys being here. Without any further ado, I'm going to send it over to Rachel and let's get started.
Great, thank you. It's really great to be here with you all. I am located in the Midwest, so wish I were out there with you all so I could see the splendid beauty of Washington State. Next slide, please. All right, so just a little bit about me. I have been doing this work for over 25 years. Designing and implementing permanent supportive housing, supported employment, assertive community treatment teams, peer provider best practice programs. And prior to joining the Technical Assistance Collaborative, which is a national nonprofit TA firm, I worked at Central City Concern in Portland, Oregon as the Director of Supportive Housing and Employment and the Public Policy Director, as well as in Denver, Colorado at the Colorado Coalition for the Homeless, overseeing their substance treatment service programs and their Housing First and street outreach programs. So it's been a long journey, and probably, yeah, next slide. It's so in today's agenda, as Kimberly mentioned, we're going to really be talking about sort of the reasoning, the rationale behind fidelity, the permanent supportive housing fidelity scales. I'm going to check in with you all on your expectations and desires for your learning today. We're definitely going to talk about racial equity as a guiding principle, and recovery and inclusion of persons served, and program design, PSH model, and fidelity dimensions, engaging people served. And then we're really going to spend a nice amount of time looking at the dimension 7 in the fidelity scale, which is flexible voluntary services. If there's time for Q&A, though we do have questions throughout, we'll have that. And we really want everyone to stay for the closing survey poll, because it helps us, gives us feedback regarding, how to make sure that you're getting the most out of this for the next session. So next slide. All right, so in the chat, I would love if you would actually, if your name is on your screen, you do not need to put your name because it'll show up in the chat as such, but maybe your title and one thing you hope to learn during today's training. And while you guys are doing that, I'm going to go ahead and move to the next slide. So we've got a lot to cover. All right. I always love to start with, you know, a nod to recovery, right? Because why are we here? What is the purpose of the work that we are doing? What is it that we want and hope for the people who we have the privilege to offer services to? We want recovery, right? We want to promote people to be able to achieve their optimum and most highest potential, just like we want that for ourselves. So I have here the SAMHSA, the Substance Abuse Mental Health Services Administration, which funds a lot of behavioral health services. You all are probably familiar with them at the federal level. This is their definition of recovery. And I always just like to, you know, remind myself anytime that I'm reviewing the slide that these 4 dimensions, good health, safe and stable housing, community that includes relationships and social networks of friends, and a sense of purpose achieved by having meaningful daily activities, independence, income, and resources to participate in society. Who here doesn't want that for themselves or their children or their siblings? You know, who doesn't want this, right? We all want this. And it's a good reminder for us when we're working with the people that we're serving that we need to center that in all of the work that we do. All right, next slide. Recovery and racial equity. I think it's really important to recognize that racial, ethnic, gender, and sexual minorities often suffer from poor behavioral health outcomes due to multiple factors that we will discuss here in a moment. These populations often bear a disproportionately high burden of disability resulting from mental disorders that are further compounded by inequities and disparities. Racial and ethnic minority groups are less likely to receive mental health and substance use disorder treatment. That's a link to the study that cites that, than their white counterparts. And then for more on this topic, you can click on either of these links. And I think that as we're going, Kimberly or Rayanne or Tony will be including the links in the chat should you want to grab them. My preference would be that you not open them, but that you maybe copy those and put those into an email to yourself so that you can reference this later. And then Shelley says, hope to learn more about equitable and flexible services with our clients. That's great. We'll really work to cover that. So the next slide really kind of outlines the barriers to care that affect access to treatment by members of marginalized communities. So lack of insurance or underinsured. We know, you know, in Washington state, you all did expand Medicaid, which is super cool because it means that folks are eligible based on very low income, right? They don't have to have a federally recognized disabling condition to qualify for Medicaid. And you may know that not every state has done that. Stigma of behavioral health conditions in some communities and cultures, there's stigma associated with expressing a need for help related to mental health problems, or there may be some myths about mental health. And so this is a barrier to accessing services, but also another really significant barrier is lack of diversity among the behavioral health workforce. So I don't know about your all's agencies, but the agencies that I have worked for in the past, I would say that we had far fewer Black and Indigenous people of color on our staff than represented the population that we were serving as a percentage. And I'd also say that when we did, oftentimes those staff were more serving at frontline positions and not in management or leadership positions. So, this may certainly impact individuals' willingness or degree of comfort to come in and seek out services. And then lack of culturally responsive providers. So just because we have representation doesn't mean that our staff are offering culturally responsive services. So there needs to be a recognition of the ways in which we offer behavioral health services in a culturally responsive manner. And in order to do that, we have to sometimes make modifications. We really need to include people from the community in how to make our programs and services more culturally responsive and accessible. And then, of course, language barriers, right? The majority of the staff and the agencies I have worked with, first language is English. And we might have had a few Latinx staff, and who speak Spanish, but maybe they aren't trained as interpreters, right? And so we really need to center making sure that language is not a barrier. And then the last one is distrust of healthcare systems. So I'm sure folks are familiar with the various different examples in which in the name of science and research, that we have lots of examples. The Tuskegee Airmen study, where Black men were infected with syphilis, and rather than giving them treatment with penicillin, once they discovered that that would work, they withheld it because they wanted to see the progression of that illness. So there are lots of examples of why people may not feel trusting of the healthcare system. And feel free, if you all have questions, to put those in the chat. I may ask Rayanne or Kimberly to just help me as I really kind of focus on the slides. Okay, and then, so the evolution of housing and services, and I think this one may have an animation component. So if you all can just click the next slide and just go ahead and click and I'll tell you when to stop. All right, so whoops, okay, there you go, perfect. So the evolution of housing and services, how did we arrive where we are today with permanent supportive housing being the model? Well, back in the 70s, right, and even 80s, we really relied on institutionalizing people. People may live in shelters or on the streets, but they would kind of, like, as a crisis occurred, revolving door into an institutional level of setting. And then we moved into a little bit forward, and there was 24-hour supervised congregate setting transitional housing models. And this was really sort of seen as a maintenance model. We're gonna put folks in these supervised congregate settings, and the best we can hope for is to just maintain. We're not really thinking about employment. We're not really thinking about meaningful activities or relationships. It's just really, okay, this is a safe place to keep people. And then a little bit closer to now, supervised shared apartment settings, and people having to meet prerequisites and skill building before they can obtain their own housing. So this is the linear model. Like, you basically gotta show us that you can live in the community in the shared apartment setting before we're even going to talk about your own place, right? And now we've kind of arrived at this place of permanent supportive housing, people having their own apartment where they have their name on the lease, and we're doing community-based services. That in vivo means in community, skill building, and it's really centered recovery, which is really a beautiful segue into FCS, right? Because the FCS model is around helping folks be successful in their own apartments in the community and offering employment support so people can have meaningful vocation that helps all of us. Like, I can't imagine for myself what my mental health would be like if I didn't have a job. Okay, next slide. Okay, what is permanent supportive housing? Hopefully you guys know this, but it is community-based housing targeted to extremely low income households with serious mental illness and long-term disabilities, including those exiting homelessness and institutions. And permanent supportive housing combines permanent housing with case management and wraparound care. So you can see here, we've got deeply affordable rental housing on the left, voluntary, we're going to talk about this later, flexible, community-based services, and that equals permanent supportive housing. Next slide. Okay, so why PSH? What's so great about PSH? What do we think that it offers to the people that we serve? Well, we know through research that it offers improved quality of life and helps people to attain their desires in the community. It promotes housing stability and retention and reduces return to congregate settings. It improves health outcomes, reduce time spent homeless and on the streets or in shelters, reduction in admissions to the emergency room, reduction in hospitalizations, greater participation in mental health and substance abuse treatment and medical care, and it's cost effective. And the person's more desired housing option. So people would prefer to live in their own apartment than to be living in a congregate setting, assuming that all of the supports that an individual needs and wants are available. And that is a big assumption, and we're going to talk about that in a little bit. Next slide. Okay. So what is an evidence-based PSH Fidelity scale? And actually, I am going to blow up my screen so I can see all of you. I'm going to attempt to do this because I would like to see a show of hands, because that'll be faster, as to how many of your well, I think all of you all have been through a fidelity review, your programs, right? So if you are newer and did not get to participate in that fidelity review, can you raise your hands? Okay, Stephen, Kim, Jennifer, Deborah. Okay, so we have a number of folks who haven't yet participated. So this is great.
I thought you said who did participate.
No, I'm sorry, who did
participate?
Yeah. So who did not? Let's do a show of hands who did not participate. Okay, Kim, Michael, Stephen, and Deborah, and Gina. Okay, perfect, great. So now let me reduce this little image on my screen so I can see my slides. So, oh, and Rebecca. What is a fidelity scale? And what is EBP? EBP stands for evidence-based practice. And something becomes evidence-based practice when research documents that it effectively improves the intended outcomes. A fidelity scale is designed based on research findings on effective permanent supportive housing programming and the indicators of practice that operationalize the key principles. I like to call it a recipe for a program, right? Like, you can't improvise too much, and you can't cut out, like, if you want to make this beautiful cake, like, and I'm like, well, I don't really feel like using baking soda today, what's going to happen to my cake? So that is what a fidelity scale. It's a recipe that has to be followed closely. So it's a tool for providers, mental health agencies, and other interested parties to use to assess their housing operation and to determine how closely their program matches the ideal or the recipe for PSH. Programs scoring high on fidelity, we know, have better outcomes for the person served. And the scale comprises 7 dimensions and related indicators for each that are measured using a score. And on this series of webinars, we're going to be talking about 4 of those dimensions, but today we're just focusing on 1. The highest possible score is 28, and PSH programs that score below 18 are not considered to be faithful to the PSH model and often have poor outcomes for the target population. And I highlight target here. I'm a little bit of a nerd. I'm trying to think of like people who are like, right, the stereotype of like chemists or neuroscientists where it's like, oh my God, you know so much about this, like just give me a break. So I say target population in bold because what I know, having been involved since almost the beginning of PSH, which dates me, is that a lot of communities are offering PSH to populations that don't have serious mental illness and may not need that level of service. So a lot of communities say they're doing PSH, but they're really not. So, all right, next slide. Okay, so the core principles and PSH fidelity dimensions. So this is where I'm going to refer to my notes because I want to make sure that I am going over each of these with as much detail. Here we go. So the first dimension that's measured in a fidelity scale is choice of housing. So this means that people choose where they want to live. Now I understand we're in this like, right, worst ever rental market in the history of our lives, probably in the history of humankind. Partially because we didn't rent apartments back in, you know, the 1800s or whatever, but you get what I mean. You guys know it, you're living this. But we can ensure choice by making sure people understand what their options are, right? And if somebody says, you know what, I know this is the only unit that's available right now, but I don't want it, then we don't discharge them from the program. We work with them until we find another unit. Functional separation of housing and services. This is another area where oftentimes it's hard for providers to meet fidelity. So people can receive services from any provider. Leaving one provider does not impact housing. So actually that's not quite very descriptive. So really, if you are the housing case management team for PSH, you should not be the property manager also that is making sure that adherence to the lease is happening. And really your sole job in this model is to represent and support the interests of your participant to remain stably housed, and if they're evicted by a landlord, to support them in exiting that successfully. Also, I just want to back to choice of housing. There's also with housing with PSH, there's no prerequisite for housing placement. So we can't, if we're going to call ourselves PSH, we cannot require that folks be clean and sober, or that we can't require that they enter alcohol and drug treatment. We can't require that they're taking their medications as prescribed, because that kind of is antithetical to the choice component. Let's move on to the third one, decent, safe, and affordable housing. So here, housing is inspected and inspected regularly to ensure housing quality standards. So we're not going to place people into housing where we wouldn't live because it's not safe and it's not decent and it's not affordable. Rights of tenancy. So people have the same rights of tenancy as anyone and everyone else. So, you know, if I am Rachel Post and I want to go rent an apartment tomorrow in, you know, downtown Madison, Wisconsin, I've got to sign a lease and I have to agree to the standards in that lease, and the lease is in my name and I come and go as I please. I've got my own key. That's what we're looking for folks that we're serving through PSH. Housing access and privacy. So everyone meeting the housing requirement will have access and will have privacy in their home. So this means that, and we're going to spend some time on some of these in future sessions, but like that I have access to my home whenever I want. And also, I'm not going to allow anyone into my home unless I say it's okay. And then finally, flexible voluntary services. And we will move on because that's really what we're talking about today. Next slide. Okay, I'm just going to quickly, Kimberly, any questions that have come into the chat? No.
I'm not seeing any questions.
Okay.
Yeah.
All right, I'm just looking at what people hope to achieve today. I would like to learn different resources that we can utilize to assist our clients, equitable, flexible services, learning what flexibility looks like. That's great. Oh, good, we're going there now. Equitable and flexible services. I hope to support my team in learning some additional ways to services are equitable and flexible, supportive housing lead. Wanting to learn all I can to share with my team. I'm just happy to be here. Oh, good, thank you. All right, great. Perfect. All right, let me jump onto my screen here. So integration and coordination of care supports goal attainment. So this is really important. So closely coordinating services with other providers ensures that all are aware of the individual's goals and are working to support the person toward goal attainment to the same end, including family, significant others as supports, leads to more positive outcomes. So I don't know, oh my gosh. Do you guys have Kaiser Permanente in Washington? Okay, I don't know if any of you receive your services from Kaiser, but what I love about Kaiser when I lived in Portland, Oregon, was that they were like the most sophisticated, they did the most sophisticated care coordination across my different specialty docs. Like, I just kind of thought that's how it was in the rest of the world. And it was a really rude awakening when I moved to Madison. And I'm with like the University of Wisconsin health system, like supposedly one of the top in the country. But my God, my primary care doctor does not know, my lung doctor doesn't know what my primary care doctor did or what my liver doctor, I have some genetic disorder. So, and it's maddening. And then like, I don't know if you've heard of Epic, which is supposed to be like the best electronic medical record in the country. They can't find anything in there. So I have a new appreciation for how important it is that we do everything to integrate and coordinate care. So that means if you guys on this call are not part of a community mental health center, or your agency does not operate alcohol and drug treatment, or you do not offer benefits acquisition supports, or you do not assist folks with acquiring food, or you're not part of a federally qualified healthcare clinic where somebody needs their specialty health conditions, you guys have got to do that work. You guys have got to convince through all just kinds of like building relationship with the people you're serving to sign releases so that you can coordinate their care. Okay. And thank you, Kimberly, for the Yes. Okay. The importance of engagement. Engagement is the strengths-based process through which individuals with mental health conditions form a healing connection with people that support their recovery and wellness within the context of family, culture, and community. Poor engagement may lead to worse clinical outcomes. I'm not even going to say may, I'm going to say will lead to worse clinical outcomes with symptom relapse and rehospitalization. The way in which you engage with individuals you serve is setting that tone in the very beginning is the most important thing to being able to successfully assist folks in PSH and for them to continue receiving services and stay enrolled in your program until they're ready to transition to independent living with no support services if that time comes. Or so here, thinking about the racial, ethnic, gender orientation of our client population, if we employ only staff who are representative of what used to be the majority white population, we might have some difficulties with some of the folks who are representative of communities of color. So it is really important to work to be an organization that hires and retains and promotes people that are representative of the entire population. And that includes hiring people with lived expertise, whether they're hired as certified peers or whether they're hired as case managers or program directors or executive directors. And I can think of examples of agencies where I have worked where people with lived expertise are at every level of the organization. Okay, next slide. Okay, again, developing rapport and partnership is used in all three phases of tenancy. So talking with folks early on about recovery, digging into what they want, like what is important to a person. Is it a job? Is it a relationship? Is it their own apartment? Is it reuniting with their kids? Is it, reuniting with other family members, and building enthusiasm, support, self-efficacy, and optimism. And so it's really important as the program manager of a PSH program to support your staff to continually assess a person's level of engagement, and to, sometimes we gotta like switch folks out. Ideally, you've got, a multidisciplinary team of staff, and there's some flexibility, similar to the assertive community treatment team, where you can say, okay, you know what? I'm going to pick on which of you is a program manager or director. Raise a hand. I think somebody here. Okay, I'm going to pick on Jennifer. You know what, Jennifer? LaWanda just does not seem to engage well with you. And there's no reason you need to take that personally, but I just wonder if, in order to get her to re-engage with our program, if maybe instead we want to ask Jasmine to cover this, right? We got to do that. And we got to also then work to continually assess our case managers' skill sets and what kind of additional training they might need to improve their engagement. All right, next slide. We are going to be getting into more interactive. Here we go. Awesome. Okay, so now we're really going to do this deep dive into the flexible voluntary services. And these are measured. So for those of you who haven't been a part of a Fidelity review and you weren't familiar with what a Fidelity scale is, there are, I'm going to pick on Rayanne now. How many items are there in the total? Oh, in the total scale, do you recall? of the entire from 1 to 7. There are a lot.
Oh, no, off the top of my head, yeah.
Kimberly, I don't know if you can recall. No. Okay. But you will see the scale. You will have all of these items laid out similar to this. So 7.1, tenant service preferences. And the reviewer will interview staff, interview the program director, interview your executive director, possibly board members, individuals who are receiving services to determine, where am I going to rate this program on this? So tenants are primary authors of the service plan. So that's one thing we're going to measure. Are the tenants in your program the primary author of the service plan? And if so, well, how do I know that as a fidelity reviewer? Like what? Oh, a little over 20 in the entire scale. Thank you, Kimberly. And then opportunity to modify service selection in real time. Okay, and Dre says, I think it is important to remember that we illustrate this not only with action, but also in our respective, yes, exactly. And that's where, if you look at the question below here, is like, how are you documenting this? So that when a reviewer comes in, that they can measure this. So some ways in which we document that the tenant is a primary author of the service plan is that they've signed it. And in my case notes, I say, I sat down today with LaWanda and we reviewed her service plan. She requested that we make this, that, and what other change. And now we can see as a reviewer that those changes are in the updated service plan and that she has signed it. So, oh, no worries, Dre. Thank you for your comment. So opportunity to modify service selection in real time. So in real time means that the tenant, they don't have to wait for a predetermined period of time, 6 months from now, to opt into receiving services they have identified they want and need. So the case manager should be working from the service plan during every encounter and through motivational interviewing, be helping tenant to identify additional services they would like to help to achieve their goal. So that's how we know if a service plan is being modified in real time, is we're going to see those updates in the service plan. Okay, service options. So the extent to which tenants are able to choose from an array of services received. So tenants need to be oriented to their eligibility for their specific housing subsidy and understand if it is tied to receiving services they don't want. It's the program's responsibility to offer services using person-centered engagement and relational strategies that support rapport building so that individuals want the supportive services that may promote their desired goals. So the extent to which tenants are able to choose from an array of services they receive. And then the next one is extent to which services can be changed to meet tenants' changing needs and preferences. So a broad array of services offered with location intensity and frequency based on the tenant's changing needs and preferences. Okay, so what does that mean? Case managers should have capacity to evaluate with the tenant their changing needs in an ongoing manner. It's not time limited, and to work to assist access to all the services needed and desired. Ongoing supports need to include assessment of needs beyond simply just their housing stability and their activities of daily living, and should include evaluating for desires to address behavioral health and health conditions, desires for education and employment programming, and opportunities for improving social connections. So again, how do we document that you are meeting these measures, will a reviewer be able to easily measure the degree to which your program is documenting this? Next slide. I'm gonna start asking you guys some questions in a minute here after this next slide. All right, so consumer-driven services. So here in 7.3a, the reviewers are looking at the extent to which services are consumer-driven and person-centered. So a PSH program can work to incorporate the perspectives of those in program design, monitoring, and continuous quality improvement through a number of measures, including appointment of PSH representatives to the agency's board of directors, to subcommittees of the board, through participation in continuous quality improvement monitoring, and or through regularly scheduled tenant focus groups. So that actually, sorry, that's a little bit more than what 7.3a is. 7.3a, you know, if I am a reviewer and I see that every single program participant has the same services listed, I'm probably going to conclude that this is not a consumer-driven, person-centered plan. What I might conclude is that, like, oh, okay, this program said you can receive this, that, and the other. Oh, and by the way, we really strongly need you to do that. We're not going to force you to, but, you know, and the person's like, okay, that might be an explanation as to why every service plan looks the same and is not consumer driven. This is where participant feedback comes in. Do you have a formal feedback loop? So how is this being used? Yeah, good question. And that's where maybe those consumer surveys. Again, I'm hoping that we're going to see in the chart notes that, you know, on this visit, the person said, you know what, I think I'm finally ready to think about going to alcohol and drug treatment, but I don't want to go in this part of town because that's where all my triggers are. So could you help me find a treatment provider in this other area, anywhere except for this? Like, I'm going to see that in the notes, right? And I'm going to see it in the updates from the service plan. Okay, availability, quality, and adequacy of services. So this is measured. We have extent to which services are provided with optimum caseload sizes of no more than 15:1, because that's what the research tells us is the most effective in terms of making sure that we can be working with folks in the community, that we're checking in on folks, that behavioral health services are team-based and integrated. That's where earlier I said, hopefully you all are operating where you don't have like, this is my caseload, that's your caseload. And well, I don't know what happened to him because that's not my problem, right? That your managers are facilitating that you as a team are serving this group of individuals. And service availability, the extent to which services are provided 24 hours a day, 7 days a week. Now I know and I understand, because I have run these programs, that some communities don't do this. I was going to say don't have capacity, but I'm just going to leave it at don't do this. They task that to their mobile crisis, the city's mobile crisis hotline. And I'm going to speak from experience of why I think it's important, with the assumption that you have the resources. I understand you may not have the resources, and that is an issue then for whoever your funder is. But it is very different to respond to a crisis to someone I have a history of knowledge of, and who has been a part of our service team and who I've heard talk about regularly in terms of what they're working on, than if I'm someone on a call center who doesn't know this person from Adam, or maybe, you know, it's a call center that somehow pulls data related to, you know, their criminal justice involvement. And then, right, like that's where things can go really far south. That's where you can, I am 100%, I would bet my house on this, more likely able to de-escalate a crisis without having to call police or have a person end up in the emergency room or tased. If you know that person and you have a relationship with them, than if you are just a stranger. Okay. So I am just looking at my notes to see what else. Again, 4B, so the integrated part, we talked about this. Integrated behavioral services using a team-based approach promotes optimal care coordination, even when separate providers are providing different components of services. So you guys might be the PSH housing specialist, and it could be that the case manager is employed by a community mental health agency, and there's a different substance use disorder treatment provider and a support employment specialist with an entirely different agency, and the psychiatric prescriber, maybe they're with a community mental health agency, but we know this person has lots of health conditions and they're getting their health care from a community health clinic, right? We can still coordinate. We can, I've done it. It takes a little more effort, and it requires memorandum of understanding. It requires proper releases of information. It requires people being willing to join weekly calls, to do staffings. So it can happen. I know it's not easy, and I know sometimes this or that provider may, you know, be challenging to work with, but you know, I think you've got Kimberly and Rayanne here who can help you all maybe with cultivating relationships where they don't exist if you do have those other systems. Okay, and then, you know, back to this 15-to-1 case ratio, you know, it's also important because it improves staff satisfaction. And I don't know how many of you all have had difficulty retaining your workforce, but we know that sharing a caseload and this staffing ratio definitely improves staff satisfaction. You don't feel like you're on your own. You've got support, you have capacity to deliver services that folks want and need when they want and need it. And, you know, also working with this population, you know, things can occur unpredictably, and we need to be able to respond in real time. And it's easier to do that when we have that kind of a staffing ratio. Okay. So on to the next slide. Now I'm going to ask you all some questions. So back to the 7.1, tenants are primary authors of service plans, opportunity to modify service selection in real time. So I would love for you all to chime in, and feel free to come off mute, or if you'd prefer to answer in the chat, that's okay too. So how does your team develop the service plan, and in what way is the tenant included? And I have resorted to calling on people. Oh, Dre, please come off mute.
I'll chime in. So our participants are the authors of our plans. We call them credible plans. We kind of guide them to a degree to try and keep it, you know, housing focused. But they are the authors ultimately. You know, we use quotes in it. We, you know, explain the dimensions that we're looking to populate, and we let them basically fill in the blank from there. So they're entirely in control of their service plans.
That's great. So let me ask you this. I love you guys are using quotes. They're the author. You sort of talk about the categories. If someone's having a difficult time, like let's say in the category of, I don't know, I mean, what's a category that we can use as an example that you have in your service plan?
Sometimes so we have the dark, so the intervention, or sorry, not the intervention, the objective portion. So that's kind of the action steps that they're going to be taking. Sometimes we kind of have to spitball with them to help them understand the steps getting to that goal. And then a light bulb will go up, oh yeah, I have to do that and I have to do that. So stuff like that.
Okay. How about other folks? I'm curious as to how, if somebody says they want something that isn't housing related, let's say they say, you know what, in the past when I've had a job, like I feel like I do better. I just feel like it helps me stay out of trouble. I know this is a PSH housing program, but like, you know, anyone else that can give an example of how you might incorporate that or help an individual incorporate that into their service plan?
This is Gina from Lifeline. We, you know, if they bring up other needs such as that, we let them know of resources available and ask if, you know, they would want a referral. If we have it internally, great. If not, we would tell them. But then if that is something they want to continue working on, we would add it to their plan. And whatever intervention the staff is doing to help would, you know, be documented. Like if they're gonna call with them, we'll call, or maybe the staff just sends a referral. And then whatever the client says, like they're gonna work on around that, like, yeah, I want to meet with them, or I'll draft up a resume. We would still put that on there, so that we can check in with them later to see about their progress. So it doesn't have to be housing specific, of course. But it would still be their, you know, their lead if that's something they want to add to their plan and want referral made.
Yeah, great. So a referral might be made, assistance with a phone call if the person says they want that. Sometimes folks need a ride or they need help figuring out. Jennifer, you have your, oh, sorry, Nina, you have your hand up.
Hi, yes. Sorry for the technical difficulties. Okay, so I actually deal with like a lot of this with my clients because I have more community clients than I do. I have more clients that are in the community right now than I have that are at the place I normally work out of at Accor. So I have this come up a lot, especially once I've already gotten them into their housing. They kind of rush me with that. Oh, okay, well now I'm gonna need this. I need bedding. I need this. I need a backpack. How am I gonna get here? What am I gonna need to carry this? You know, so in that moment, it's kind of depending on where they're housing that, which is, we've gotten pretty blessed with like them going into Oxford or some type of shared living to where they have other people there that they can use and reference. Like, oh, hey, I know a really good clothing bank that's right down the street that we normally go to, or we go to the food bank every Thursday to yada, yada, yada. So those are normally when those supports like really kick in and really help us out that are already, you know, doing, helping them with a lot of the work. I say for myself doing, because I'm learning boundaries at the moment. I'm one of those people, I like to, you know, go above and beyond, and I can easily find myself doing more than I should. But I am one of those resourceful people that I know where to get a lot of that stuff due to the life experiences I've gone through. I know where to get a lot of that nitty gritty things that housing wouldn't necessarily supply. So normally, just like when we normally go through like doing our assessment processes and stuff, there's a process to it. We start the assessment first, and the next day we come back, we do their creditable plan, we find out their goals, what they're looking for. So I do that when I'm in the community with them. Hey, I'm dropping you off.
Yeah.
Here's your housing, get acquainted with them, talk with your people, and then call me when there isn't something that you haven't been able to find. And then I'll look that up for you and we'll figure out how to move that forward. Now, if it's something as far as like doing a ride or something like that, because we have people, for instance, that are in drug court. And when they get out, they get out of treatment, they're going to drug court, they're going to go check in. A lot of these people, are already feel insecure about going and checking in with them, because not only do they look different from how they were when they opted into drug court, but they're really acting different now, because now they're thinking about things, they want to do things, they're motivated. So it's kind of like they're still iffy, that trust factor. So normally they want somebody to go with them. I assisted a client a couple weeks back in going to his first like in-person court appearance for drug court, and he's like, yo, you go with me.
Yeah.
I don't want to walk in there, by myself, and I was flattered at the same time, but like, wow, me, because the last time I went in front of them, it was a little different situation.
Definitely.
So it worked out great for the both of us. But that is something that I did assist them in. And I'm glad that, our team, if we're able to, when we put those community client services in, we're able to get reimbursement if we're driving them up the road and back.
Yeah.
So it works pretty good.
That's great. Thank you so much for sharing.
And then of course we log that in our DART.
Yes, we got it. We
log
got to
all of
document
that.
it.
Yeah.
Because the reviewers, if they don't see it, it didn't happen.
Yes.
So
I've learned many lessons on that.
Yeah. But that
Yeah.
sounds fantastic. Yes,
Mhm.
absolutely. Going with folks when they're not feeling secure, and have good reason, right? Good reason with their history of not feeling safe sometimes doing things. So, Deborah, you have your hand raised.
Yeah, I was just going to piggyback off of what Dre typed in the chat. There's usually a way to loop housing into almost every conversation we have, or any situation that comes up. Jen taught me that, and I use it. I work a lot inside the facility, and I use that a lot. There's just, if you really dig deep, you can almost always loop housing in some way.
Yeah. Great. All right. Well, in the interest of time, because we still have a lot and we only have, I think, a half hour, is that right, left? I'm going to move on, but I would encourage you guys as a team, if you have time, to print these slides and ask yourselves these questions as a team, right? Because that's a really good exercise to help you improve the quality of the services as well as the documentation. So service options 7.2, so extent to which tenants are able to choose the services they receive, including no services, and extent to which services can be changed to meet tenants' changing needs and preferences. So what process is used to review members' individual service plans for their changing needs and desires? How is this being monitored? At what increments are ISPs being reviewed and updated? Any of those questions, or what happens for you when somebody says, I don't want any services?
Are you asking us a question, Rachel?
Yeah, anybody.
Oh.
Yeah,
Okay.
Nina, go.
I just wanted to, so I know for myself, because I'm kind of getting into the routine of updating stuff when my clients have completed something or done something. I go into their credible plan because I know that's something that I can make changes to. I know that that's something that I can put in, that we completed this on this day. And normally, like, I take a lot of notes, so I don't only take notes that are on my DARP. That's like my final finish, but I have like tons of like notebooks and everything and papers that when I put them all together, I'm able to be like, oh, oh, this week so-and-so completed this. Okay, good. Oh, so this goes with that goal that he had that went back when we earlier started. So then I can just go back and I can change the goal that we completed that, and then put in those little notes on this is when he did this and this
Yeah.
is what led to this.
Great.
So then not only when you're showing what leads to, then I feel like us as an FCS team, with just what Dre and Jennifer have talked with me about, that's where they build that. That's what makes them want to, that's what makes the state and the government want to help us, because it shows the footwork and shows the progress of the person on
Yeah.
their actually making those deep-seated changes that's going to help them sustain their life.
Yeah.
Otherwise it's for nothing.
Right.
Right.
Thank you, Nina. Anyone else feel moved to respond to any of these questions under 7.2?
This is Gina. I have
Yeah.
a question. I was just typing in the chat, but I'll just ask.
Sure.
Because a extent to which tenants are able to choose the services they receive, including no services. I was just wondering if you had advice. We have a client, a PSH client, who has higher level symptoms, the highest of all of our PSH client, and she tends to use a lot of triangulation across
Mhm.
our departments and even the funder Department of Commerce. And so sometimes she doesn't want services, whether that's really what she wants or not. That's what she's telling us. And then others she does, or sometimes she only wants certain type of service that we can't provide. For example, would be like only wanting to go back to a hotel that will not allow her back, for example. And so I was just wondering, like, if you have advice on, where that flexibility comes in. We kind of just keep the door open for when she's
Yeah.
ready. But
Yeah.
the
I mean, I think,
Yeah.
thank you. No, that is a frequent occurrence. Where somebody says, I don't want services from you. I don't want you coming over here and checking in on me. And no, I don't want to ride to that appointment or that provider. So, I think this is where our, I feel like it ought to be in a job description for PSH providers, like that you have to be charming. And I always use self-deprecation, like, oh, I'm so stupid. I can't believe, that like I just, forgot this. And so where folks can be like, oh, no, it's okay. Right. And it puts them in a position of feeling like, okay, this person's flawed, or this person, like, their self-esteem, I think that somehow, sometimes can kind of level the playing field. And then, I learned so much from my rock star street outreach workers in Denver, because they were amazing at building relationship and rapport. And, they would show up with somebody's favorite, coffee beverage. And I don't know if you all have the budget to be able to do that. Or say, hey, I wanna get you in to see, your doctor, because I'm concerned about this, whatever, your, skin infection. How about, can we go like get some McDonald's on the way, and just like, it'll just make me feel better. Can we just do that? Is that okay? Like, I'm sure that you all are using those types of skills with the folks you're working with. And again, maybe trying like a different person. Like there really are some folks who just have a difficult time working with program participants who triangulate, or who people may sort of come to categorize as having a personality disorder. But like that, it's our job to sort of be creative and think about like, what can we do to continue to just try. And I heard you say that, Gina, like you guys are leaving the door open. But people can also, people who have those types of disposition, they can sense when somebody when a staff person is responding in a way where they feel angry or resentful because they feel like they're manipulated, people pick that up. And so it's our job to figure out how to not let people, I mean, ideally not to feel that way. And if not, you know, at least that we can control, you know, we can hide that.
Yeah.
So.
Thank you.
Sure. And Kimberly said, having a carrot to dangle is always helpful to engage folks. If you need support and ideas of what that can look like, please reach out. And Rayanne says, I find that dialing back and taking some intentional time to be curious about that person, asking about history and their experience helps redirect and pause. Yes, the stress to build rapport quickly. Yeah, those are really great offerings as well. Okay, let's move to this third. You know what? I'm gonna consumer-driven services. So extent to which services are consumer-driven, person-centered. So I am not going to spend time here, but I, again, would love for you guys to spend time here. What policies are in place to operationalize consumer-driven services? What are the current tracking mechanisms for this? And how is continuous quality improvement feedback loop employed to improve this? So do you have individuals serving on your board of directors who have lived experience? Do you do focus groups with program participants that are perhaps even co-facilitated by people with lived experience who are now staff? Do you have a survey that folks are participating in? How, in what ways does your organization really bake that in? Because it's critically important. Okay, next slide. So the availability, quality, and adequacy of services. So extent to which services are provided with optimum caseload sizes, no more than 15:1. Behavioral health services are team-based. And service availability, extent to which services are provided 24 hours and 7 days a week. And I saw Rayanne responded. Oh, okay, that was just, of course, great question. Okay, so how does your program manage caseload sizes that exceed a 15:1? How do you measure the team-based integrated approach to service delivery? How are you addressing fidelity metric that requires a 24-hour, 7-day-a-week availability? Any of those questions, would anyone like to come off mute or put something in the chat?
This is Kimberly. I just want to point out that 7.4b is where a lot of agencies take big hits in fidelity. So this idea of coordination of care and integrating the behavioral health side of the house into our housing plans and to what we're doing is really, really crucial to what we do and gets missed in a lot of ways. So this is one that we see a lot of hits in fidelity on. And so I would love for you guys to give us or talk about some ideas you've done to work on this, or what you do as an agency to talk about this, because this is a big one that we talk about a lot.
It is super important. Yes, Kim.
So, for right now, the facility I work out of, we're a very small team. And so we've tried to, I'm fairly new, so I staff things regularly with my lead and my supervisor, and you know, to make sure I'm on base and that we're, you know, coordinating everything we should be. And I know a lot of from my previous work, a lot of the community providers, and so trying to incorporate those when I know, you know, that somebody's working with somebody, say a Compass or whatever. So
great. I think, you know, and maybe Kimberly, well, it sounds like Kimberly and Rayanne can spend more time with you all on like, what does this look like? Because I know they have lots of ideas about how to, if you don't have a formal memorandum of understanding with the other service providers, how can you work to achieve that? What are some ideas for staffing? If this other service provider clinic is serving, 10 of your 50 PSH clients, can we do that staffing where all 10 happen during the same hour once a week? So it's not like this, like all over the place, right? So I would really, oh, and Rayanne, you have a comment.
Yeah, I just had a question, perhaps something that we see kind of across the board when we're talking about this part is, like the environment that your community is in. So we hear a lot of agencies who say like, yes, and I want to collaborate and I want to do this, and we really struggle with this other agency, XYZ, whatever. So I was curious, Rachel, like in your experience, and maybe could you talk about that? Like, what are some ways that you would do that if like the biggest community mental health place is not, you guys don't maybe align with housing choice and things like that?
Yeah, that's a great question. Wow. And I hope that the office hours that some of you all are going to participate, we can do a deeper dive into this question, because we'll have a whole hour just with one agency to focus on that. But, this stuff takes time, right? Like we're throwing a lot at you. And, you may be some distance from, being able to secure like a high score on each of these, but it takes time. And I think it's the ongoing effort. And, I always tell programs like it takes 2 to 3 years to get a really solid, 2 Fidelity program in place. And that's without a lot of turnover of leadership, right? And that's with buy-in from your executive director, right? In my efforts over the years to work towards Fidelity in my Housing First programs or in my SOAR programs, which is the SSIDI, securing folks, we had to go to executive directors. Sometimes we had to go to mayors. One time I went to the, and I know this sounds like over the top, but I went to the federal administrator of the Social Security Program administration when Oregon was refusing to process the SSI claims in an expedited manner. So I realize not everybody has the authority, but hopefully your manager or your director does and can take that up to the next level if you're being met with resistance and sort of the hearts and minds have to be changed. Like, okay, you may not agree with this low barrier housing, but this is a model that we are delivering based on the state of Washington's agreement with the Centers for Medicare and Medicaid. And we need to be able to work in partnership with you. So that's my short answer. I want to go ahead and move on to this case study because I'm really excited and I know we're running short on time. So next slide. This is where we get to sort of practice have a conversation based on some of what we talked about today. So this is, I'd like you all to think, I like to go and visit sites of services just to open communications. Yes, before direct agenda to address as an introduction. Yeah, great. So thinking about what we've been discussing today, I'd like you to think about this particular case study. So Jamie is a 34-year-old Native American woman who is referred to your program with a diagnosis of bipolar disorder who actively uses injection drugs. Prior to her most recent stay in the shelter, her referral identifies she was cycling from unsheltered homelessness to the emergency room for the past couple of years and has had brief inpatient admissions resulting from mental health crises. You learn that she has had multiple interruptions in her mental health care at a community mental health center which she reports was a result of not being listened to. Jamie reports that she is willing to enroll in your PSH program, but doesn't want any mental health or drug treatment. She reports a desire to reunite with her 8-year-old son who was placed into foster care setting at 6 years old. So how do we work to engage Jamie into our PSH program using flexible and voluntary services? What best practices can we use to engage her in receipt of services, which she says she doesn't want? So anyone, oh, Nina's got her hand up.
Yeah, well, I just wanted to speak on this really quick because I feel like this is where my life experience, this is what helps me with my clients of this sort, because I just came from this myself. So this is where I would just talk with this woman and talk to her. I would share a little bit about myself. I'd share a little bit about myself, my story, where I come from and what I've just went through.
Great.
And her reuniting with her son. If this is something that she really and truly wants, you're going to have to engage in services because CPS is going to require it. So if you engage in services with us, I can understand, you know, I would talk to her about, I understand where her insecurities might lie about not wanting to go and do treatment, not wanting to go, I'll do this. You know, this is something that I can relate with her on understanding. I know that you don't want to do. But if you want to see your son and you want to make things happen for him, and not only that, but what if you do get him back? If you're doing all this stuff, you're going to get him back. That's inevitable, whether it's going to take a year or 5 years, it can happen. What work do you want to put in? So this is where I would ask her, what's her expectation of me, of us as services, you know?
Great. Thank you, Nina. Thank you. Very powerful. Yep. Sharing some of your personal story. So Jennifer, I saw that you had your hand up.
Yeah, I just wanted to say, so basically a good way to engage with people sometimes is to talk about the difference between engaging in services and then the natural consequences that are going to happen if they don't, right? Like you're free to make these choices, but here's what might happen if you decide not to, or here's what might happen if you do. So doing like pros and cons with somebody, talking through that we're here for you, we're available, you know, and we deal with this quite a bit, right? Because they're like, well, I don't want to do that and I'm not going to do this. Well, then unfortunately that door might not still be open for them. We're still going to be by their side as we look for another door, right? But really making sure they understand that, yeah, they are free to choose the services or not, no services, and all back on that same, you know, the choosing no services, which is okay. But if they choose no services, unfortunately, some doors might be closed. And once that happens, how's that going to feel or look? So kind of playing that tape through with them, looking to the future, what could happen there. And a lot of times that in itself builds enough rapport to say, well, I might give it a chance. Let's just go check out that. Maybe I should do an assessment, right? Maybe I should get back into treatment. Maybe that would look good for the court, right? So all that stuff, really just bringing it back. So it is the ball's in their court, but making sure they understand what they do with the ball is going to change the direction. Or like also reminding them, we aren't miracle workers, you know, we don't have a magic wand. And so if certain programs or certain things they're doing require certain things, then we'll help you through that process, but we can't solve it for you. We can't just make it all go away.
Yeah. Thank you, Jennifer. Andrea, I really appreciate your comment about starting with getting a better understanding of her history that led to not wanting services. Like, yeah, like what does not being listened to look like? What does it feel like? What, you know, maybe there's some trauma related to that, right? Like maybe she was, sorry, Dre, go ahead.
Just to expand on that a little bit, I think it's really important to remember, kind of as you had started this training, I think it's important to remember that a lot of people that we work with have been harmed by the very system they feel like they're being forced into. So whether it's direct or indirect, you know, it really their perception of the situation is all that matters, because that's where the harm is felt. So I think it's important to remember that, you know, trying to twist somebody's arm to get potentially hurt again is, you know, is not going to work. So understanding why they have the perspective that they have, understanding how they got to where they're at, and helping them to understand that we are at our foundation an advocate for them. We don't operate for that system. We are there for them specifically, and it is our job to make things as seamless and, I don't want to say comfortable, but to make the process as painless as possible through whatever supports and resources we have to utilize.
Yeah, thank you so much. And Jasmine echoed that, and talking about really ask a lot of questions and listen, right? Because this woman's reporting that she wasn't listened to. So I think that's really important. Like, okay, we want to listen. And who doesn't want to be listened to or understood? And then Alana says, hearing her, telling her about the PSH program and how it revolves around client choice, also going over the strengths part of assessment on ways we support. I take out my phone and go to available homes and talk about how we help someone find something they like and want, then asking what she wants. That's great. That's beautiful. You guys got this. All right, well, let's move on to the next slide. I want to just quickly finish this up. I really look forward to those of you who are going to be in a one-on-one office hour, because we get to continue this conversation. So additional considerations. I think we've talked a lot about this. Does your staff reflect the racial, ethnic, gender, sexual orientation of your tenant population? And if not, then what can you do to work towards that? How is your program utilizing those with lived expertise in your staffing? I heard a lot of folks today talking about their own personal experience, so that's beautiful. What are the roles and job titles of those with lived expertise? And in what ways are services culturally responsive? So if you are not currently engaged with if you're not providing culturally responsive services, are there community-based organizations in your community that you can reach out to? Can you reach out to those agencies to talk with them about what you're doing and how you might be able to make it more culturally responsive? Can you put out publicly that your agency is really working to grow in that area, which may help to attract more people of color or people from other marginalized communities to apply and work at your agency if they know that, like, this is an agency that's working to change. So I think with that, I do not think we have enough time for questions and answers but Kimberly and Rayanne, I really want folks to be able to complete the exit poll. Are there closing thoughts that you guys have?
You know, really, I think just this is such a good topic in terms of, like, it takes so much more like inner work, looking at your team and how might we do these things. And I think some of the questions that you posed, right, like, are really like good nuggets to kind of chew on. And you know, we work with humans, so things are complicated, right? And to know, like, what are we all doing? What are we all striving for at the end of the day? You know, and to know that you can move forward with your team in that way. And I think really identifying, right, what are our values as a team, and how do we do this as we walk forward? So I'm excited. I'm really hopeful that you guys take advantage of that one-on-one TA time and really can do some dive into this, because it takes a lot of vulnerability on your end, right? And we want to respect that. Like, it takes a time to say, like, maybe I'm not doing this part super great, but to come and say, I want to know better, I want to do better. So I'm excited for you guys to just kind of get some more information, and I'm very much looking forward to learning about your program and learning about the creative ways that you guys are making stuff happen. So I just want to say thank you very much for setting some time aside to engage through this process with us, and hopefully you can, you know, do the you know, do the survey and stuff and give us some good feedback, because we'd like to keep things like this available for you guys.
Yeah, and then also, I think the hyperlink for the registration for the August 4th, if someone, Kimberly or Rayanne, you can put that into the chat if you haven't registered, and there'll be 2 more after that. And then I know, Kimberly, did you want to talk about the survey as well?
Yeah, so I appreciate you guys being here today. Just like, just kind of want to say thank you. Just like Rianne, we're really appreciative that you're taking the time to think about these things and look at these things, and that you're participating in Fidelity. So, Fidelity is really about, getting to that really top quality of service, making sure that we're doing it consistently across the board, and that people are being served well, and that you're able to learn from one another in doing this. So if you haven't already seen that we sent out a survey around Fidelity through our listserv, we are going to send it out again today, but I'd love for you all who have participated in Fidelity, or your agency has, or maybe you haven't participated, to fill out this survey and let us know what are some of the reasons why you do it, why you may not do it. There's some questions there that we'd love to get feedback on as we move forward into, Fidelity really becoming part of what we do, in the work to ensure that our folks are being served well. So we'd love to get some feedback as we're moving forward into FCS and the work we're doing in supportive housing and supportive employment. That feedback is super helpful in guiding us as we move forward and making FCS a permanent benefit. And so you guys that are doing this work, it's super helpful to hear from you on why your agency chooses Fidelity or maybe hasn't participated yet. And we appreciate all of you being here. It does, we know that we're asking you to take time away from the folks you're serving to do this, but it just shows your commitment to the work, and we do really want to honor that. So thank you again, and thank you for filling out this poll. We want to make sure that these trainings that we do provide that are more targeted are honoring your time, and that you are getting what you need from it. Want to remind you that there is some open office hours for Rachel to connect with you as an agency one-on-one. So if you aren't one of the agencies that have reached out to me and said, yes, we want to meet with Rachel, then please let me know on the side that that's something you would want to do, and we can make sure to set that up for you. So I think that's all I have. Rachel, anything else?
Yeah, I just want to echo the appreciation. Like this takes time, and it is a learning process. And, I think just by showing up and every day and the work that you do with curiosity, gets us so far. I also just want to say that Kimberly and Rayanne are phenomenal resources to you. And, you're gonna run into obstacles and challenges that you may need a little more support around. And, the example given of an agency that doesn't want to work with you, or something that just, isn't working at a system wide, and Kimberly and Rayanne, they're with the state, and they can, support you. They've seen everything in every community, so don't hesitate to rely on them for support. Thank you all so much for the incredible work you do, and I feel inspired just by getting to hear you all talk today, because I'm not doing this stuff anymore on the front line. So thank you for your service.
Yes, thanks everyone. We appreciate your hard work out there. We know that it's not an easy job. I want to remind you that we see you. We know that you're working out in the trenches to support people, and we couldn't do this work without you guys out there doing that. So thank you again, and please have a great week. Rest of your week, I guess we're at the end now, and we look forward to seeing you at the next training. Take care, everyone.